Hello, my name is Kate Chesterman. Welcome to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify and Apple and Google podcasts. Please follow us to receive notifications about new episodes, and if you like what you hear, please consider leaving a review to help other listeners find us. You can also visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. Today, I'm going to be considering a common and harmless condition that can nevertheless cause distress in some people due to its appearance. Keratosis pilaris is a complaint that results in bumpy and rough skin that can feel like permanent goosebumps. And the terms chicken skin or strawberry legs, although descriptive, do nothing to reconcile those who have the condition to its appearance. So what is keratosis pilaris? Why does it occur? And is there anything that we can recommend to those who are hoping to improve the look and feel of their skin? So keratosis pilaris often starts in childhood, and it affects around 50 to 70% of teenagers and around 40% of adults. It is not infectious, but there does seem to be some genetic predisposition, with an increased prevalence amongst those with affected first-degree relatives. There is variation in the way that it is inherited, but it often appears to fit into an autosomal dominant pattern. Keratosis pilaris is caused by the keratinous plugging of hair follicles. This scale fills the hair follicles and is not naturally exfoliated, and this results in the bumpy appearance of the skin and its rough, dry feel. These bumps are small, usually around 1 to 2 millimeters, multiple and painless. They are usually skin-coloured, but can be white, red or pinkish purple on fair skin or brownish black on darker skin tones. There are varying degrees of perifollicular erythema, and there can be an associated itch. The condition occurs primarily on the upper arms and anterior thighs, but it can also be seen on the buttocks, lower back and chest, and rarely on the face and eyebrows. Very occasionally, there is associated redness and pigmentation of the skin of the cheeks, loss of eyebrow hair, and small atrophic areas over the cheeks. Keratosis pilaris cannot be cured, but it often, although not always, clears up in adulthood. Unfortunately, any atrophy or scarring with hair loss will be permanent. Keratosis pilaris often appears worse over the winter months, as the skin is generally drier, and the constant rubbing of the skin against thicker clothing aggravates the complaint. It may be associated with other skin conditions, such as ichthyosis vulgaris, which is an inherited skin condition that causes excessively dry, thick and scaly skin, and atopic eczema. There also appears to be an association with other atopic conditions, as well as obesity, insulin-dependent diabetes, and Down syndrome. So, what treatment can we suggest? Well, for those who are not concerned about the condition, it may be best to simply reassure and wait for the problem to improve on its own. Clearing can happen gradually over several years, even without any treatment. For those who are concerned by the appearance or any associated itching, there is advice and treatments that can improve the condition, albeit temporarily and only while the treatments are being used. Simple advice, such as mild unperfumed soaps and bathing products, gently exfoliating the skin with a cloth or exfoliating mitten, and having cool showers or baths can be helpful. Patients should be encouraged to avoid harsh scrubs, perfumed soaps, hot baths, and scratching or picking at the skin, as these can all exacerbate the condition. Shaving and waxing can also worsen the bumps, so consideration needs to be given to hair removal. We should also encourage regular emollients which soften the texture of the skin. These should be applied 2 to 3 times a day including after every bath or shower. Following a bath or shower, it's recommended to apply the emollient within 5 minutes. And emollients containing keratolytic substances, such as salicylic acid, lactic acid or urea, are particularly helpful as they can soften and flatten the bumps. Interestingly, topical retinoids have also been shown to reduce redness and the rough texture of the skin and might be considered in recalcitrant cases, but they can cause local irritation, which may limit their use. Topical corticosteroids are rarely indicated, but could be prescribed on a short-term basis for a few days, for example to reduce erythema prior to an important social occasion, but they should not be continued long-term. Other treatments that have been tried, including photodynamic therapy, various laser treatments, chemical peels and dermabrasion, are not available on the NHS due to their expense and lack of proven efficacy. So, thank you all for listening. I hope you found this podcast helpful. Please do have a look at the show notes that accompany this episode at GPnotebook.com. Feel free to email support@GPnotebook.com if you have any questions, comments, or ideas for future podcast episodes. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and download free shortcuts, which are designed to help make your lives a little easier and ultimately help improve the lives of our patients in primary care.